recognized for his leadership. He continues to shape policy, practice, and workforce development to reduce healthcare-associated infections and antimicrobial resistance, advancing for safer healthcare delivery at a bigger scale. And being a president of the Infection Control Academy of India and also honorary professor at the Hyderabad Central University and Public Health Foundation of India, he builds scalable frameworks to develop globally competent infection prevention and control workforce, positioning India as the strategic hub for global health and capacity strengthening. With his work, he integrates infection prevention, antimicrobial stewardship, and pandemic preparedness as a fundamental pillars for resilient health system and critical to achieve safer, effective, and people-centered care under the universal health coverage agenda. Sir, thank you very much for your time. We request you to take over the session and introduce Madam to the forum. Thank you very much, sir.
Thank you, Ganesh. Thank you for that very generous introduction. Good evening, colleagues. Good evening, Dr. Kalyani, and
good evening, sir.
All of you, whoever is joining, either it is good morning, good afternoon, or good night. A very warm welcome to all of you on behalf of Infection Control Academy of India, University of Hyderabad, and also Sunmed Healthcare, which has been putting extreme efforts actually to make this IPC Masterclass a possibility. Now we are into season 7 of this IPC Masterclass, and also today is the chapter 3 of the 7th edition. Since given the opportunity, probably I would like to share a few remarks before I hand over to Dr. Kalyani. When it comes to all of us as healthcare professionals, I would not say even workers, professionals, we often speak about innovation. Recently, we started even talking about artificial intelligence, machine learning, robotic surgery, precision medicine, etc., etc. At the same time, when we examine the real world's best performing healthcare systems, a very different lesson emerges. The success of those, who are doing well is not built solely on the resources, infrastructure, or technology. We often blame our inability or the poor practices on them, and hence I would like to underline that our relentless adherence to the fundamentals will make all the difference, not all that what technology, what I have mentioned. Just a day back, I am back from Singapore, where I had very lengthy interactions with the colleagues at National University of Singapore, Ministry of Health, Singapore, etc., meeting the healthcare leaders there. And during my 8 days of journey, delivering few keynotes and also meeting with all the people, I was reminded that the difference between good hospitals and great hospitals is rarely the availability of the resources. I did not say bad hospitals. I would say good hospitals and the great hospitals. And the difference actually lies in disciplined execution, unwavering compliance with the evidence-based practices, continuous measurement, accountability, and a culture, most important, a culture where fundamentals are respected every single day and for every single patient, who comes to us for the care and for solace from their disease and also pain. And hence, infection prevention and control is perhaps the finest example of this particular principle. I don't want to go into saying that, how big is the problem of healthcare-associated infections. Neither I am going to tell you the preventable causes of patient harm is in our hands. You are already aware of that. And most importantly, coming to this day's topic and also the Series 7, is that we are discussing about a very important HAI called as SSI, surgical site infections. And you all, better than me, aware of the significant contribution of SSIs to morbidity, mortality, prolonged hospital stay, antimicrobial consumption, which again goes into the circle of creating the antimicrobial resistance and the healthcare costs. But these infections, although they are preventable, somehow, somewhere, something is not happening, which is actually closing that loop, ensuring that we are going to have the global level benchmark practices in our country, in our institutions, including our pride of our nation, All India Institute of Medical Sciences, across the nation. The first two chapters of this masterclass reinforce this particular message that we need to do better. And when it comes to the chapter 1, which you have already had the opportunity to listen to, focused on understanding and preventing SSI risk through patient optimization, surveillance, and evidence-based prevention strategies. And when it comes to the chapter 2, which we also had the pleasure of actually listening to one of the colleagues from AIG, has highlighted the critical role of sterile processing and instrument reprocessing, and reminding us that every instrument correctly reprocessed represents an infection prevented and patient protected, right? Today, I think, we have to move beyond individual interventions to a very broad and broader and increasingly important perspective, that is surgical care continuum. Our understanding of SSI prevention certainly is evolving. I would not say that it has evolved and we know everything. And as far as I am concerned, I am very fascinated about emerging microbiome and genomic research, which suggests that many infections may arise not only from the healthcare environment, but also from the patient's own microbial flora. At the same time, we know that environmental controls, sterile processing, operation theater discipline, AMSP, perioperative optimization, postoperative care, all of them certainly, of course, contribute cumulatively to the overall outcomes of our work. So the implication here is very, very clear. That is that SSI prevention does not begin with the first incision, nor end with skin closure. It all begins when a patient is first evaluated for surgery and continues through all the steps, which probably Madam would talk about today. Every step in that patient journey presents for us as infection preventionists and the healthcare professionals is an opportunity either to reduce risk or to introduce it. Choice is ours. The future of SSI, therefore, lies in integrated systems that deliver reliability across the entire continuum of care. And today, I think, I am sure we are fortunate to have with us an expert uniquely positioned to guide us on this discussion and also, to give us the pearls of wisdom, which we had to carry from this particular session. And today it is my honor and pleasure to introduce Dr. Kalyani Suryadhanalakshmi, Professor of Anesthesiology at All India Institute of Medical Sciences, BB Nagar, which has been rapidly expanding and giving a tough fight to the private care, especially in Hyderabad, probably. Dr. Kalyani brings together clinical excellence, academic scholarship, and a deep commitment to patient safety. Her expertise spans many countries, namely India, Ireland, Kuwait, providing her with a very broad international and national perspective on perioperative care. I was told that she has made significant contributions to medical education, airway management, critical care, pain medicine, research, quality improvement. I can go on. And most importantly, anesthesiologists like her occupy a very unique position within the surgical ecosystem. They accompany patients through every critical phase of the perioperative journey, and therefore they bring a comprehensive perspective on the concept of surgical care continuum. Few are better placed than Dr. Kalyani to address today's theme. Encourage all of you, the participants, to engage actively and reflect on how the lessons from today's sessions can be translated into practice within our own institutions. Because ultimately, excellence in infection prevention and control is not achieved through occasional brilliance. It is achieved through unwavering commitment to the basics, performed correctly, consistently, and collectively. With that, it is again my greatest pleasure to invite Dr. Kalyani to deliver today's masterclass on infection prevention across surgical care continuum. Dr. Kalyani, the virtual floor is yours, madam.
So thank you very much, sir, for that beautiful introduction. And I thank Sandmed for inviting me out here for this wonderful session. So I'll start sharing my slides and can you see my slides?
Not yet.
Not yet. Okay.
Yes, ma'am, we can see it right
Yes.
now. Can you
All
make the
right.
full screen, ma'am?
Yes, on it. So good afternoon, everybody. I'm Dr. Kalyani. I'm an anesthesiologist, and I think the first question you must be wondering is, if it is surgery, why am I talking about SSIs? So that is to say, we do contribute. We do contribute to the safety and in prevention. And I think we are we watch over what's happening and what should not be happening. Because of that, we are closely related into looking out for surgical site infections, preventing it, and I also identifying potential causes. So coming down to what is a SSI? So surgical site infection now is defined as any infection in and around the wound site, right? Which happens after the surgery. And depending on when it is presenting, it could be up to 30 days or up to 90 days or a year if from the surgery when the infection is presenting, and especially if there has been an implant, that's when the duration you take it up to a year after the surgery. So this infection could be localized, can present as pus, and we have to be aware that this plays a very important role for the patient. Now, why this is very important is I'm very closely associated. I had a cousin who had osteomyelitis. And let me tell you, of the foot, he had 18 surgeries. And finally, I've understood that some infections, especially of the bone, are literally like a cancer. They are torturing you for the rest of your life. So this is something we definitely want to prevent for any patient. So what is the burden? The burden, as you can see, unfortunately, men are more than women, and nearly 2 to 5% of the surgical patients are affected globally. But in India, nearly 3,500 to 5,000 patients are in a lack of population. And amongst these, unfortunately, 72% are elective surgeries. So we generally expect emergency surgeries to be having infection, but no, here 72% are elective surgeries and 81% are first time surgeries. So somewhere something is not going correctly. So we need to introspect as to what could be the potential causes. So that's the poll 1 now.
Here is the result, ma'am. Okay.
Okay.
Yes.
All right. So I'll proceed.
Yes.
So here, next question. Where do SSIs really come from? So the traditional model, which we had been finding out, we have been doing is exogenous contamination, hospital environment, surfaces, hands, ventilation, instruments transmit pathogens of the patient during care. Now, all this has cut down because we have come down to barriers, environmental cleaning. The CSSD and sterile processing has become excellent. The environmental cleaning has become more, and still they found that patients are still getting surgical site infections. And that's where the next set of evidence has been started, where endogenous, the patient's own flora, 80 to 86% are arising from the nose, skin, and gut. So now we have to re-establish that we have conquered one, which is the exogenous one, and this we have not actually addressed properly. So the genomic evidence is saying that the patient's own flora would be the cause. So this is a small study done in 2024 where they actually saw 86% of the infections were from the patient's own flora. 55% were antibiotic resistant and 0% had any common source. So there was no source. Patient was the person providing the infection. So what can we do? From the skin, we have the indwelling flora within the skin. Nearly 30% are carriers of Staphylococcus aureus in the nasal cavity. You can have translocation from the colorectal and abdominal surgeries. And recent evidence actually found that degenerative discs and joints harbor discrete microbiomes. So this has been very revealing. Coming back to global burden, how do we define the surgical site infections? So superficial incisions, that's around skin to subcutaneous tissue, they're present within 30 days. Then we have the deep incisional, deep soft tissue, fascia, muscle, and anything in the deepened organs, which can present from 30 days, or as I said, 90 days to 1 year with an implant. And this in America is 20% of all healthcare associated infections, which increases the mortality nearly 11-fold and increases the hospital stay by 9.7 days. And I actually hesitate to look at the burden. 3.3 billion annual drain on US healthcare, which is now I think they're wasting on Iran. So what are the causes of surgical site infections? We need to think big. It is multifactorial. Some things can be modified, some things cannot be modified. So amongst the patient factors, we have advanced age, more than 65 years, and immunocompromised state. And when we say immunocompromised state, patient could be having cancer, he could be on chemotherapy, drugs, or he could be an inborn having immunodeficiencies, obesity with a BMI of more than 35, poorly controlled diabetes, and something as simple as smoking and severe malnutrition could also be caused one of the underlying factors. So we need to be aware and take extra measures when we or optimize the patient before we take them. Now coming to procedure related, emergency surgeries and prolonged operative duration. So they said surgeries more than 3 hours by themselves are more likely to get surgical site infections. Simple. An open surgery, obviously skin incision is bigger. You have more chances of infection. than a laparoscopic surgery where there's a small incision. And here we play the role intraoperative hypothermia. So as anesthesiologists, we do see that the patients have normal temperature, do not go into hypothermia, and presence of implants and foreign material like meshes, your screws, needles, all that comes into higher likelihood to have an infection. Coming to environmental, does it make a difference? Yes. Inadequate OR ventilation, or airborne bioburden. Simple. OT door is frequently being opened. So the moment the door opens, the laminar airflow systems are all disrupted and the air from outside comes into the room, causing more infections. And as I think you had a previous class, surgical instrument contamination and dull instruments also play a role. Now the second poll.
Poll has been launched. Here is the result for the poll. Thank you for polling. Ma'am, you can continue.
All right. My slides are just a second. So we have said that there are several causes as to when the surgical site infection occurs. Now, what we need to understand is we need to be like a big team, wherein right from preoperatively to intraoperatively to postoperatively, we work together. So even when there is a failure of system, as simple as the antibiotic which was supposed to be given in the preoperative area is not given and that handover is not done. So that's a communication failure. So this prophylactic antibiotic not being given to the patient could have caused a surgical site infection. So we need to have several layers of checklist so that this doesn't happen. And each hospital has its unique set of systems. We need to have a system which works in your institute to prevent the common problems that happen there. So the Swiss cheese model is one which is adopted by the airlines so that safety is the priority. This also is done in the operation theater by having several layers of checklist, right from patient handover to the WHO checklist to again handover back to the ward where they are sent with all the adequate information. So what is the first defense? First defense, like if it's an elective surgery, lifestyle. We can ask the patient to stop smoking so that the oxygen delivery is improved. Improve their nutrition so that they are protein loading. Second, if they have anemia, correct the anemia. And most importantly, glycemic control. If the patient is diabetic, we have to see the sugars are under control so that that itself improves the immune system. And in the preoperative period, maybe it's not that relevant to our country where it's very hot. It's very much relevant to the West where the patients would be hypothermic right in the pre-op area where the warming starts. So aseptic discipline. Despite everything, surgical hand prep has to be done. Environmental barriers have to be taken. And most importantly, flattening of hierarchy. Sometimes the junior most is following the rules while the senior most is not. And then they cannot tell the senior most to follow the rules. So somewhere we have to flatten the hierarchy so that we are able to talk properly. There should be no hesitation. There should be no accusations. So, and this will improve the communication barrier so that there is no hesitancy in saying something has gone wrong and we can correct it. And the SBAR protocols, standardized critical handoffs. So situation, background, assessment, recommendation to prevent assumption-based errors. So already again, sterilization standards, these are very important, have to be strictly followed. Expiry dates have to be seen. And as we should know that disposable FDA cleared sterile devices are best. However, it is not economical and cannot be done in our country. However, a good CSSD with strict protocols is amazing in reducing the surgical site infections all over the institute. Now, point of view sterilization and compounding. If there is an instrument which is single, falls down, we should have a SOP as to how we are going to use that instrument by having what process of sterilization. And that is the most important bit, especially in the operation theater. Now, what is now documented and maybe assessed is that dull instruments can retain microscopic material and could be invisible vectors for surgical site infections. Coming to what happens intraoperatively. Now, this is very amazing. Routinely, irrigation is done with saline. Now, the evidence says use povidone iodine to lavage the surgical sites. And do not recommend antibiotics to be added to your irrigations. I hope all of your hospitals have WHO checklist, which is very important, not only in safety, but also in preventing infections. Because here, double check is done whether the antibiotic has been given or not. It is part of the process for the last literally 15 to 20 years. And here we have to also understand something as simple as shaving. Shaving should not be done on the surgical site. Clippers should only be used and it should be on table. Coming to hyperoxygenation, that is in contention. WHO did come up with hyperoxygenation. It is no longer used. Now we use 50% oxygen because people do not agree with it. Something as simple as checking all our patients for nasal swabbing for Staphylococcus aureus, we can prevent by giving them intranasal mupirocin. The evidence is around 20 to 25% are carriers, right? So here we are come from treating the infection to actively understanding what is the cause of infection and going to the grassroots level to reduce it. So as I already said, we have to do screening, optimization, maintain sugars, skin preparation, and most importantly, only clipping, no shaving, and strict site antisepsis using either chlorhexidine or povidone iodine alcohol. The recommendations are whatever you use, but do use alcohol again, which has found to be very useful. Now, what about the use of laminar airflow theaters? Yes, especially when they're doing knee replacements where there's an implant which is being put, it would be most useful. And the highest level of HEPA, the filters, the laminar airflows have double set of HEPA filters with literally more than 99.97% removal of particles and as small as 0.3 micron size of particles are removed. Now, the air changes range from 20 to 25 cycles per second of the air under the laminar airflow. The latest laminar airflows also have a UV disinfection. It is still not a part of enhanced recovery, but they are trying to recommend it. Right now, the evidence is not much, regarding a great significant decrease in surgical site infections with the use of laminar airflow. Poll 3.
Poll has been launched. Please share your opinions. This is the result. Thank you, ma'am. You can continue.
So I hear this is where I feel as anesthetists, we make a big difference. We do, despite the surgery being done, we see that the antibiotic, most importantly, a single dose antibiotic is given within 15, the recommendation is 60 minutes. We in our institute, within 15 minutes of the incision, before the incision, we try to get the antibiotic in. What we need to remember is when there are long duration surgeries, depending on the half-life of the drug, we have to repeat the dose, or when there is more than 1500 ml of blood loss, repeat the antibiotic dose. Strict normothermia. So not only pre-warming, we also use warming devices like bear huggers, warm fluids, especially in prolonged surgeries, so that, and temperature is monitored right from when the patient is come inside the theater to when we shift him out. So the temperature is between 36 to 37 degrees centigrade is maintained. Tissue oxygenation, obviously, we are always on point on that, and that is never ignored. The other thing which I felt was very difficult to control is limit OR opening. Till literally 5 or 10 years ago, there was not much research. Now there is increasing real-time studies which saying increased traffic, increased personnel inside the OT do increase the surgical site infections. So number of human beings in the OT should be restricted, because we are all a big microbiome of several bacteria. So the more they say the number of bacteria in our body is literally like the size of our brain. And so each of us is carrying so many bacteria, that makes sense that more people, more infection. Now, again, we have to use, if we have not, I'm going to change practices here by thank you for this class, that we are going to start using povidone iodine in irrigation. The other thing, having some bit of evidence, is using triclosan coated sutures to actively inhibit bacterial colonization and biofilm formation. Now, this is again contentious. Operation theater fogging. What does CDC say? CDC says routine fogging is not required. It relies on validated HVAC system, that is humidity, ventilation, and air conditioning systems, and HEPA filters. However, when fogging is indicated when we have an infective case, especially a multi-drug resistant pathogen, or terminal weekly once disinfections, or OTs idle for more than 12 hours, new OTs, outbreak of infections, or when we don't have an HVAC system which is validated. That means each HVAC system has to be, every 6 months it has to be tested, and we have to ensure that there are more than 20 air changes in a minute, and the HEPA filters have to be changed. So commonly used fogging agents include hydrogen peroxide, silver acetate, peracetic acid, whatever is used. If we do not have a HEPA filter or a laminar airflow, we should, take highest measures for cleanliness. And amongst this, most importantly, is cleaning the theater on all surfaces between surgeries, and with as simple any high level disinfectant. So all surfaces which are in contact up to the contact areas should be cleaned between each patient, and that has been found to be very, very useful. Using soap water also is very effective. Now I wanted to go back here again because of Spalding's classification, because you have different items. He has classified as critical. So critical includes surgical instruments and implants where the highest level of sterilization is needed. Now, what are the semi-critical items which we use? So these include endoscopes, laparoscopic equipment, laryngoscopes. These need high-level disinfectant where we use paraldehyde or any soaking solution, which is a high-level disinfectant to clear these items. Non-critical, BP cuff and stethoscope. Even these, we have to see that we should clean with at least some material between each patient. Now, what are the sterilization methods available? We have the steam autoclave, which is the gold standard. Then we have ETO, for all the items which are plastic, which cannot be put into the heating cycle of 134 degrees centigrade. The downside of ethylene oxide is it's not very green, could cause some trauma to the, side effects to the healthcare workers, and it needs a long shelf life. Now, if I want to put the laparoscope, I have to put it for overnight before I can use the laparoscope again. And this is where the plasma sterilizer comes into use, where in an hour we can sterilize items which are plastic or very sensitive, which cannot be autoclaved and can be used within the hour. Now, what's upcoming? This is exciting. So what is exciting is, I'm sorry, I think I missed a slide here. WHO has been very importantly, it has saying that please do hand scrub, and where water is not available, you can also use alcohol-based hand rubs versus the traditional scrub where the water quality dependency is, we're not very, not a good quality water. However, they say do not use brushes because that causes microabrasions. And most importantly is we need to increase the effectiveness of the scrub. That means we have to take cognizance that we're doing it in the right way. And what I have found is every 3 months that the scrubbing becomes less effective. So continuous training, videos, feedback, so that the morale and motivation of the healthcare worker is maintained. So that's there. And coming to the digital frontiers, and this was exciting. You can have an AI prediction tool, which actually, we put in data, patient is 65-year-old, he has diabetes, he's going for an onco surgery, duration of surgery is going to be long, and this will give you, it'll flag, it's a high risk, take these precautions, So it targets, so AI prediction can be used. And most importantly, we have smart dressings, which actually says, temperature is higher, color change, pH is low, there is acidosis, and it tells you very early this onset of infection. So that's the poll for now.
Ma'am, you can continue, ma'am.
Can I?
Yeah.
So the post-op surveillance telemonitoring, where from home the patient sends a pic with the pain level, and remotely the doctor can monitor and identify when the infection has come. There is a digital twinning also, which I found very difficult to understand, but with the patient data and all the inputs of physiology, virtually they are simulating the real-time data. And this is anticipatory. So all in all, I wanted to say that no single measure will prevent an infection. So the CSSD, the world's best CSSD is useless if the most important people here, the human, our healthcare workers, do not follow protocol, or there's a break in the sterility chain. And if we have not coming back again, as a team, we have not prepared the patient properly with ERAS guideline, glycemic control, nutrition, and then intraoperatively, we have maintained all our checklists. So it's a bundle. No single one measure will go on to prevent a surgical site infection. It is a teamwork and strict adhesion to our protocols. And also, if there is a failure of a system, a feedback, a good communication, yes, we missed the antibiotic dose. Okay, let us give it now. So we have identified a problem and we have sorted it out. All right. So this is not only system issue. As humans, we need to have a good communication, a feedback system. Any change in protocols has to be again informed. All this together will lead to a zero harm. And most importantly here, with the global crisis of antimicrobial resistance going on, escalating and giving highest level of antibiotic is not the solution. As it's this masterclass is all about identifying, understanding that it is a multi-system. At multi-system level, we have to be integrated, identifying any problems in our system and correcting it. And as I like to say, most important in all this is the patient, and us as healthcare workers will make the maximum difference in preventing the surgical site infections. So coming to the Indian practice, fogging is a reasonable compensatory measure if we do not have a HVAC system. Alcohol-based health rubs can be used where water quality is unreliable. Antibiotic stewardship, there is no compromise. A generally clean case, single dose of antibiotic prophylaxis is enough and does not make any difference even if you give repeated doses of antibiotic, which is actually increasing the burden of resistance. And bundle implementation, keep everything together. No single thing by itself is going to make a difference. Together with all systems, the patient, the ERAS protocol, the CSSD, sterilization, and our process, all of those will reduce the surgical site infections. And most importantly, the microbiological surveillance. So what do? We have an OT monitoring where we check the settle plates, surface swabs, which so that we can guide decontamination practices. So another AIMS had a 9.5 CFU per meter cube achievable with fogging. In our OTs, we have less than 15 CFUs per meter cube in our settle plates. So that's the final poll now. So I'm open to any questions.
Thank you very much, Dr. Kalyani, for that brilliant talk. I'm sure the participants have enjoyed, as I have, very intently listened to you and very intently tried and absorbed at least, few pearls, which you have thrown at us today. Couple of areas just to conclude. While Dr. Kalyani, having exposure, global exposure to countries like Ireland and other countries, probably she would have brought in some of the futuristic aspects which we need to be having idea about. But definitely, I think she has stressed on one point that basics are not replaceable, right? And our own practices, our own commitment towards the patient safety is irreplaceable by any machine, right? Forget about all those sensors, biosensors, and all that stuff. But ultimately, what matters is our own knowledge, our own understanding, and our own practice, which is going to make most of the difference for the patients. And any other equipments, and most advanced, even the AI-based and ML-based technologies, they're only going to aid us to improve and even better perform than what we have done probably yesterday and day before. While saying this, while Dr. Kalyani was actually talking about one aspect, saying that we anesthetists actually are watching every moment over the shoulder of the surgeons, it reminded me that very frequently, when I had to find a good surgeon, I always go back to my friends, anesthesiologists, in order to actually get a referral, because they are nearer to the altar. They are like pujaris, who had been nearer to the god, and they know, who is doing what kind of practices, surgical practices, what kind of infection prevention practices, most of our surgeon friends follow. So they are the most reliable people actually to ask for the suggestions on a good surgeon with good outcomes. With those words, now I'm going to actually read out a few of the questions, which are coming in question answer box. The first question I certainly did not understand, so I would not read out. The second coming from Preeti. Can you explain hyperoxygenation again, madam?
Yes. So, WHO, I think in 2010, had come up with surgical site infection prevention. They did a study, and then they said that if your oxygen, generally oxygen in the air is 21%, and they recommended that the patient should get 60% oxygen right up into the post-operative period. So as you know, in anesthesia, we give spinal anesthesia, we generally do not give oxygen. So they were recommending giving oxygen based on a few studies. And this created a lot of contention, and then now more recent studies are not backing that up. They're not saying we need to give 60% oxygen. The point here is keep the patient not hypoxia, give him the normal oxygen. So that is, WHO hasn't gone back on their stance, but the recent evidence says that too much of oxygen is also not good. Oxygen causes free radicals, and this causes internal injuries which need not be there. And it is as simple as in lungs. When you give oxygen because of the ventilation perfusion mismatch, you can actually cause atelectasis of the lungs when we give too much of oxygen. So because of all these reasons, that hyperoxygenation is no longer recommended. I wouldn't recommend. Even in the ICUs, we have gone back. It is just there to say, we don't follow it anymore.
The rules are there to break.
Yes.
This is the instance, when we had to always, apply our own mind rather than blindly following actually certain protocols. Because when the evidence is there before your eyes,
Yes.
even if the God says, I think you should actually listen to your own, intuition, and also your own knowledge and experience in order to make such decisions, what Dr. Kalyani has made. The second question, OT fumigation frequency.
Yes.
What is it? I
OT
think
fumigation frequency. Now it's as simple. CDC says don't do OT fumigation. It says don't do. However, I find proof, for me, I do it as proof that my OT is clean. So here in our OTs, because the new block is getting built, we have a lot of construction going on. We fumigate every night. Every night. And where you have a HVAC system and you have a laminar airflow, weekly once is enough, especially if the OT is idle. And I would suggest fogging depending on how your OT is, how clean is your OT, and what kind of patient have you done. So we have an HBsAg, HIV compulsorily after every HIV, HBsAg, we do fogging. If we have a very infected case, we do fogging. And that's how it is. So there is no black and white rule saying when to do. It is not recommended because they're saying just simple soap water cleaning is also cleaning up all the potential material in a normal piece, normal surgeries.
so. Just to summarize, don't overdo it.
Don't overdo it. Absolutely.
Don't overdo it.
Don't overdo it.
Because you don't need, if you have some good practices in terms of your hand hygiene, environmental hygiene, I think, most of it is taken. She has given specific instances when you must do the fumigation. I think, that is what you should segregate rather than actually taking it as a thumb rule that, because somebody is doing, let me do it and all that stuff. That takes us to the third question. What is settle plate? How to take the reading?
OT settle plate. Yes. So what we do here is the settle plates are given by the microbiology department, and it is done when the OT is not working. And these settle plates are kept in the OT. Nobody goes inside. And after an hour, they're collected and then they culture those plates. And then we also have the swabs. At the same time, we take swabs from the commonly used areas, which is suction, the OT table, workstation. So around, I think, 9 or 12 swabs are taken from all these commonly used areas at the same time. And then we send it to microbiology. So they tell us, because the settle plate shows what is happening in the air. Until now, we have never found any settle plate to grow anything.
Absolutely. I think, there is a lot of diverse kind of opinion about it. And also you need to be careful where you're going to place your plates, right?
Yes.
That is going to also make a lot of difference in terms of when do you do the settle plate, and how often you are going to do, when everybody is roaming around putting the plates and actually taking it doesn't make any sense. So you need to know actually the sequence and also the procedure. You need to have a clear SOP. There are several SOPs available. You just Google it and you will get it. And if there are any questions, approach Infection Control Academy. They must be having the ready-made kind of SOPs which you can actually take from them. The next question, how often should fogging be done? I think, already Dr. Kalyani has made it very, very clear during her presentation, and also further to the second question, she has already replied. There is nothing like a thumb rule or, a standard timeline. It depends on the situation, and every situation is different, and hence actually you had to make a call based on your understanding of the situation. Any specific time for between two surgery according to CDC guidelines for deep cleaning?
I'm not aware of it, honestly.
Yeah.
The CDC hasn't spoken anything about deep cleaning.
Between two surgeries.
Yes.
Unless
We only do it for, honestly, for HIV, HBsAg cases. Generally post them in the last, do deep clean at that time.
Yeah,
And
well, I think, the The answer could be, is it a contagious kind of situation, or a general surgery, right? That is what is probably going to define. In case of issues with HVAC system, is fogging allowed in modular OT? That is the next question.
And I don't know the answer to that.
Yeah.
Yeah.
So
So
issues means, HVAC, if it is not working, there is nothing,
you
you
have to
can do
fog.
about it. If your HVAC system is not functional, if it is not having the prerequisite, air changes and all that stuff, what do you do just by fogging? Within no time again, it will get contaminated. So you need to go back again to the root cause of the problem rather than trying to actually do the quick fixing or band-aiding, right? In this case, if your HVAC system is not functional, if it is not operational properly according to the SOPs what you have, then no amount of fogging is going to help any of us, right?
Yes,
Probably
it's
that is,
all. I
yeah.
think together we have to take it into perspective. All things have to be done together, and fogging is not the ultimate cleaner. And you have fogged, but you didn't clean all the OT with the soap water and all that doesn't work. Fogging, I think, is more like a homeopathy treatment than honestly, because everybody feels we have done the fogging, OT is sterile. No, it's not sterile. You're brought, and the moment we stepped inside, we have caused infection. If the blood falls down, again, that has to be cleaned in the correct method. Otherwise, the OT is infected.
Soon we are also going to learn Ayurveda, homeopathy, Unani, etc.,
Okay.
etc., under the new
My
curriculum.
bad. I'm
So
sorry. I withdraw.
I'm just kidding. So thank you for the presentation. Which disinfectants would you recommend for equipment such as BP cuff, stethoscope, etc.?
Yes, I went back, I read it. So there are some swabs which are available, those disposable wipes which can be used. And soap water cannot be used because BP cuff is generally made with something. If it's a cotton BP cuff, you cannot use. We have the Rexine ones which can be wiped off between each patient.
Which drug is now preferred for surgical prophylaxis?
That is an institutional protocol. It depends on the surgeon.
And
So
probably the institutional antibiotic policy
exactly. And also the type of surgery.
and the type of the surgery.
Yes.
Absolutely. Please elaborate on settle plate interpretation. I think you had a slide on CFU on your last
Yes.
slide. Share the reference. That is what is being asked.
So in our institute protocol, any growth more than 35 CFUs is considered, that cleaning is not adequate. It has to be done. So less than CFU, I think even internationally, less than 35 CFU is accepted. So I think the AIMS they had done, and they had 9.5. In our hospital, it varies, theater varies from 3 to 17. It has never gone beyond 17. So 35 is the cutoff.
Yeah. I think, anything above just, kind of, take a break, do, what we are talking about, the fogging or any other method in order to remove that contamination and then, start working again. Does SSI can cause a VAP? That's the
Can
question.
SSI cause VAP? This is a trick question because VAP is ventilator associated pneumonia. So ventilated associated pneumonia is in patients who are on the ventilator on endotracheal tube. It generally occurs between 5 to 7 days. And it is to do because of the collected secretions of the patient, improper hygiene, and the infection around there. So I would not call it an SSI because SSI means surgery was done. So SSI is surgical site infection. It is specific to the infection. So VAP is to do with a patient on the ventilator where he develops pneumonia after prolonged ventilation. So they're two different things. And maybe he's trying to say that the bacteria from the wound site went into the lung. That would not happen. Then that would be sepsis.
Authentic settle plate again, probably it is already taken care of. Authentic platform to get SOP. Yes, I think this is very important question. Probably I would take this question on behalf
Yes,
of
sir.
Dr.
Thank you
Kalyan.
so much.
Yeah. So authentic is any guidelines which are issued by the professional organizations, associations, and the governments. These are authentic platforms. To give the example in the Indian context, it is NCDC, ICMR, the professional organizations who go into the specifics. For example, Indian Surgeons Association, they have their own SOPs on certain things in relation to the surgical procedures and the prevention, what we had to follow. So all in all, it is the professional organizations, associations, or your organization called Infection Control Academy, or All India Institute of Medical Sciences, especially AIMS Delhi. They come with a lot of SOPs, very reliable, evidence-based, and after long-term studies, they fix those standards, so you can reliably follow them. Can we substitute fogging with UV light?
No, you cannot.
I think that is that's a forthright answer. Just 4 days back, I have participated in a group of 12 people, who had come from all over the world, and that particular group was organized by John Hopkins. John Hopkins has developed a wavelength of UV light called as for UV, for ultraviolet, right? So I'm going to be part of that particular project where they are looking at that particular wavelength, which can be safely deployed in the presence of the humans, right? So when those kind of technologies come, probably depending on how they are going to perform in the real time, not in the labs and the experimental things, then probably we can think of. But as of now, as Dr. Kalyani mentioned, I think we can't substitute UV light technology in its current form. Let me underline it, in its current form. As the technology is going to be much more superior in terms of their kill rate, in terms of actually their ability to work in the conditions of our own settings. I'm not talking about North India, Ireland, or somebody. I'm talking about our own, where hygiene is a big factor, where even the basic cleaning is not there. In those cases, it is definitely not going to be a substitute. Another question, madam. Use of bacillocid better than fogging? Kindly highlight. I don't know. I did not understand. Bacillocid for the application as a surface cleaner, or what is that? I don't know. Maybe
Even
you
I don't know.
understood better.
Because see, it's a high level disinfection. Each company says ours is better, this is not better, whatever. So I would not recommend any whatever fogging agent you use. Fogging is not, as I said, the solution. It is one way of cleaning your OT, which at the end of fogging is clean enough. But let us assume between the first case and the last case, we don't fog between each cases. Still, the patients do not get infected. It is a form of deep cleaning. So I would not suggest one agent over the other. Fogging is a fail-safe we use because we don't have anything else. Simple things, cleaning of all the surfaces with soap water is very good. So that is what evidence is saying. Keep your surfaces clean. See, even the ECG leads should be clean between each patient. Every drop of blood on the floor should be taken, hypochlorite solution should be used. Those are the important things. I think, focusing on fogging, the type of agent, I think is not that important. It is there, it is a part of the cleaning process, but it is not the most important way to reduce infections.
Absolutely. Just to add on to what Dr. Kalyani said, when you are choosing actually any chemical, you need to ensure that that is going to be safe. Safe for healthcare workers and safe for the patients and safe for actually your surfaces and your infrastructure. From that perspective, any aldehydes, as you know, that they can be cancerogenic. So it's better to avoid any combinations with the aldehydes. It is always better probably to look at kind of chemicals which are much more sustainable. For example, all oxygen releasing agents like hydrogen peroxide, peracetic acid, they break down into water and oxygen, and hence you would not have any residues which are going to cause the long-term impact on either the humans, who are present in that particular spaces, or the walls, the tables, and other things. So, as infection preventionists, you always need to be mindful on the aspect related to the safety, right? The safety of those chemicals, and hence, probably my suggestion, and also, what probably many organizations and guidelines suggest is to go for something more sustainable rather than actually looking at chemicals which can harm actually. Settle plate, again, we are probably going to skip that. What reagents can we use in fogging? I don't know what reagents. I don't know what is.
I have already put it
Yeah,
up. Hydrogen peroxide, peracetic acid, all
absolutely.
those high-level disinfections are used for fogging. So each
How those,
company comes up every time saying mine is better than the other. There is a H2O2 plus nitrate, all those, anything is whatever is available in the hospital. But we have to remember it's an ongoing process. Just because I cleaned it doesn't mean it's going to be clean for the rest of the day. So sterilization, maintaining asepsis is a continuous process as it's been highlighted in the title. It's continuous.
yes, absolutely. I think, for my scholars, I'm sure, some of you are here. I always keep talking about three C's when you're actually making a choice of any of the disinfectants. That is the concentration, coverage in terms of what is the spectrum of the pathogens it is going to cover, and what is the contact time, right? So of course there can be other factors, but these are minimum three C's which you need to keep in mind while making the protocol or decision for your particular healthcare institution. Is there any study regarding the healthcare associated infections due to anesthesiology procedures?
I am not aware of any specific, but I will go and look it up.
What is the correct sequence of environmental cleaning? Deep surface cleaning, then fogging, or vice versa?
Yes, deep surface cleaning and then fogging. Because
Absolutely.
any material, if it is there, any organic material cannot be sterilized. So
Yeah.
cleaning has to be done.
Thank you very much, Dr. Kalyani. Thank you all for your very active participation. There are some questions. Pardon me, if I did not actually answer. We are already out of time. One point, actually, what Dr. Kalyani has said, and again, I want to underline, is that when we are talking about SSI, especially in kind of settings what we are in, that low resource settings, LMICs, low medium income countries with inadequate infrastructure and all that stuff. And also keeping in mind the study what she has mentioned, that most of the SSIs are also attributed to the patient herself or himself. You need to give a very good kind of attention to the pre-surgical kind of stage. Probably bathing in our environment, in our settings, probably bathing the patient a night before and in the morning, where available with the gold standard like chlorhexidine. Where it is not available, probably at least with soap and water, is going to considerably reduce probably the bioburden and also the pathogen burden which they are going to bring in, which invariably is going to cause the SSI and also increase the burden in your own institution, and probably, make all the effort what the surgeons and the teams put together, making it actually going waste. So that's why probably one suggestion is, please give a lot of attention to the pre-surgical bathing. That is one thing, before I close this session, with huge applause and thanks to Dr. Kalyani for a brilliant talk and bringing a very clear understanding on this surgical care continuum. I'm sure we are going to have this dialogue continued, and looking forward to see you all in the next session and the last session of this season 7 IPC Masterclass. Thank you, guys.
Thank you, sir. Thank you very much, madam. Thank you very much for time for both of you. It really an engaging session and an enlightening session. Things are very routine, but still need to be addressed very regularly. So that's an important thing which madam has put. And like sir was saying, maybe most of the times we start ending up giving an incision before also there is a need for to take care of surgical site infection. So pre-surgical bathing may be a most important factor which can be considered at an affordable price, and that would be a very, very important factor to consider. So thank you very much for both of you. Thanks a lot, and we'll